MBBS in Human Physiology, Medicine and Surgery. He was the best graduating student, Department of Human Physiology, best graduating student in surgery. He was the president, Port Harcourt Medical Students Association. He is currently a consultant preventive cardiologist, having bagged a master's degree with distinction in preventive cardiology from the Imperial College, London, with focus on primary prevention of cardiovascular disease in high-risk groups and cardiovascular epidemiology. Dr. Amadi has published about 35 research articles. He is a fellow of the Postgraduate Medical College of Nigeria. He is a fellow of the European Society of Cardiology. He is a fellow of the American College of Cardiology. Dr. Amadi is also a fellow of the Nigerian Cardiac Society. He is an honorary consultant cardiologist at the Lagos University Teaching Hospital and an associate professor of medicine at the College of Medicine, University of Lagos. He is a member of the American Society of Preventive Cardiology and European Association of Cardiac Rehabilitation and Prevention. Dr. Kasme Amadi is a medical doctor of the he is a medical director of the Meridian Cardiac Center, Pestac, Lagos. So with a warm round of applause, please let's welcome our guest speaker, Dr. Kasme Amadi, to take the stage. You're very welcome, sir, and we are very, very excited to have you in our midst. Please take the stage, sir. Thank you so much.
Thank you, Enzo, for the kind invite to speak for you on today's World Heart Day. And thank you for a kind and elaborate introduction. Thank you very much, much appreciated. Now, distinguished ladies and gentlemen, in the next 45 minutes or 1 hour, we'll be looking at how not to miss a cardiovascular sign in a cardiovascular disease and stroke. So the whole idea is for us to quickly identify what can lead to cardiac disease or cardiac death or cause a stroke in any person we as healthcare professionals will be seen or do see from time to time. So just like the lady has kindly introduced me, for the past quarter of a century, I teach in the medical school. I teach resident doctors to become consultants like myself. I also train medical students, doctors to become consultants like myself. I treat cardiovascular disease, try to prevent it with drugs as much as I can, as much as I have been trained to do. I also talk. Companies invite me to talk from time to time. Churches invite me to talk to people from time to time. The whole idea of talking to the lay public is to find a way to identify what can lead to heart disease. Remember, I am a preventive cardiologist. My job generally is to prevent heart disease. The first heart disease and the first stroke is all I have been trained to do. So in all these years, I've been doing one reading or the other, doing research or the other. My main focus has been how do we prevent the first heart attack or first heart failure or the first stroke. Because the healthcare professionals on this call know very well that once there's a stroke, nothing can be done about it. Once there's heart failure, nothing can be done about it. The person will just slowly get out of life. So it behooves us as healthcare professionals to identify those items in the patient's medical list that will lead to a disease and prevent them from leading to heart disease or stroke or even sudden cardiac death. So these are my disclosures, but I want to also say that this webinar is sponsored by EMZO. So it's an EMZO-sponsored webinar. Thank you for reaching out. And I also want to wish everybody a happy World Heart Day. Today is 29th of September, and all over the world we use the opportunity to celebrate, the heart, because it's the engine of the body, and also to make everybody be aware that the heart is the most important organ in the body. It is the first organ in the human body to start beating, and once it starts beating, life ceases. So it's very, very important that we take time every year to celebrate the heart and also encourage the heart to be doing the work God has asked it to be doing. This year we said, don't miss a heartbeat, don't miss a beat. That means whatever whatever will make anybody lose their heart or lose their life through heart disease should and must be properly and early identified and properly managed. So this webinar will focus on how to identify early signs of heart disease and what to do with them and how to prevent them from taking place in the first place. So every heartbeat matters. So we must act early to save lives as healthcare professionals, whether you're a nurse, a pharmacist, a doctor, a consultant, or a community health worker. As long as you're in this business of saving lives, your knowledge, your skill matters a lot with respect to saving lives from heart disease. So we should not ignore the warning signs of cardiovascular disease and stroke. This year, we're also trying to highlight the importance of being vigilant, being attentive to that patient who walks into your consulting room, that patient you are doing, their vital signs, that patient you are dispensing drugs, or that patient who has come to your pharmacy shop to refill a prescription. It's very important to pay, close attention to their little complaints. You might be the only person they will ever meet that will help them prevent a heart disease or sudden death or stroke. We also know that, heart disease and stroke, present in different forms, even across, the two genders, male and female. The way a man will present with a heart disease is sometimes different from the way a woman will present with a heart disease. It's also why we need to pay attention to these, differences. And timely referral to where they can get care. If you can't help this patient, please, refer promptly. Time is of the essence. Time is muscle. Time is heart. Time is brain. We also look at how to encourage ourselves, through prevention, screening, and urgent treatment to avoid disability and death. So I'll discuss, we'll run through this webinar using this outline. First, we'll talk about the global burden of cardiovascular disease. We'll also talk about the risk factors, what can lead to heart disease and stroke. What are these warning signs and red flags we should never miss? How can we work hard not to miss any red sign or any, or any red flag? When we identify these signs and red flags, what do we do with them? And how do we prevent a healthy individual from having the signs or red flags of heart disease? Then we'll summarize, then I'll take your questions, then we'll close. So I'll start with the global burden of cardiovascular disease. Then let me start by defining cardiovascular disease. Everyone mentioned CVD. What is cardiovascular disease? Cardiovascular disease, otherwise called CVD, is a family of diseases that affect the heart. From our basic knowledge of human anatomy, we know that the heart has muscle, it has valves, and it has another covering called pericardium. Disease that can affect the heart muscle or affect pericardium will lead to cardiovascular disease. We know that the heart also has, tubes, blood vessels, bringing blood into the heart and taking blood out of the heart. Arteries take blood from the heart to other parts of the body, while veins bring the oxygenated blood from other parts of the body to the heart. If there's any disease that will affect the artery or the vein, it's also a cardiovascular disease. So when as a cardiologist, as a doctor, I'm looking at the patient who has heart disease, is that coming from the muscle or from the valves or from the pericardium or from the arteries or from the veins? With this definition, look at what cardiovascular disease, examples of cardiovascular disease. The primary one is called coronary artery disease. That means in this case, the cardiovascular disease has affected the artery that takes blood to the heart muscle. When that happens, the patient can have angina or chest pain or myocardial infarction. If it happens to the artery that takes blood to the brain, the person will suffer a stroke. Where the disease is affecting the heart muscle alone, they will have heart failure. If it's affecting the veins that take blood from the legs to the heart, the person may have pulmonary embolism or deep vein thrombosis. Now, the heart is wired like the way you wire a house with electrical wires and all that. That's where the heart is also configured that way. When the electrical system of the heart has faults, the patient will have palpitations. It's called arrhythmias. Some children, when they're between the age of 5 and 15, may have sore throat. The sore throat damages the heart valve. They end up with rheumatic heart disease. Some people who smoke or diabetics who have what's called peripheral arterial disease, the artery that takes blood to the muscles of the legs become narrowed and blocked. They will have peripheral arterial disease. This may lead to gangrene. Finally, very small amount of people have congenital heart diseases. They are born with those ones. Nobody can do anything. You can't prevent those ones from happening. But these other ones I've mentioned before, this congenital heart disease, are 100% preventable. So what about the burden? In 2023, 19.2 million deaths, which is about 32% of global deaths, came from cardiovascular disease. In other words, cardiovascular disease plus stroke accounted for 19.2 million deaths all over the world in 2023. In 2021, at the height of COVID, infection and that pandemic, cardiovascular disease was still number one, causing 18.1 million deaths. Remember, COVID killed only about 7 million people. As of 2023, 437 million persons had either died from cardiovascular disease or are living from complications from cardiovascular disease. As of that same year too, the amount of cardiovascular disease in the whole world was about 626 million cases of cardiovascular disease were recorded in 2023. But the happy thing is that 79.6% of this cardiovascular disease came from preventable, reasons. That means what caused those cardiovascular disease could have been modified, could have been prevented if attention was paid to details. The reason why, for doctors and nurses and healthcare professionals on this call, we must do whatever is necessarily possible to prevent cardiovascular disease by identifying those risk factors, which I also talk about as we go on with this presentation. Again, the sad thing about this global burden is that about 75% of this global burden of cardiovascular disease is borne by poor countries of the world, countries we call low, medium income countries of the world, like countries in Africa and Asia. Why? Why is this so? 75% of the world's population reside in these countries. And in these countries also, you have high prevalence of cardiovascular disease risk factors like hypertension, diabetes, obesity, smoking, and physical inactivity. These same people have poor health literacy. They are very, very ignorant of what can cause cardiovascular disease. In this country too, they have limited access to health care. In Nigeria, if you go to a public hospital, you understand what I'm talking about. You may not have a bed space. You may not have adequate nurses or doctors, not hurt by the Jaguar syndrome. People are also poor. Because of all these problems, they present late. When they present late, a bad case is a bad case anywhere in the world. When someone presents with stage 4 heart failure, what are you going to do? You do your best. And the patient, will definitely move on toward to mortality, what we call ward M. Sometimes, these countries have poor health systems and health infrastructure. Sometimes, they don't have, equipment to identify diseases or even to treat. In this country, to have a lot of political instability. All these things, gang up, conspire to make cardiovascular disease a very big issue in low and medium countries of the world. Cardiovascular diseases are very expensive to treat because, for the most part, they are chronic diseases, and treatment is for life. If someone has malaria, they can go and buy a packet of artesunate or whatever, 10,000, finish it under 3 days. They are fine. But someone who has hypertension has to take drugs for the rest of their lives. It doesn't apply to diabetes. Perchance they have a stroke, it becomes double jeopardy. They will take the drugs to control hypertension and take drugs to prevent another stroke. This is cost money. But look at the happy thing. The cheering is that cardiovascular disease is 100% preventable. Because from all our knowing and knowledge and understanding as healthcare professionals, 90% of causes of cardiovascular disease are known. They can either be prevented, modified, or carefully managed. In Nigeria, cardiovascular disease is also very common. More than 30% of all medical admissions in every teaching hospital is due to cardiovascular disease. So it's very, very common, very expensive to treat because they're all chronic, long-lasting conditions, and treatment is for life. But as a preventive cardiologist and as healthcare professionals, we know that the causes of cardiovascular diseases are very, very identifiable if you spend time with the patient. That means they can either be prevented or treated or managed. So what are risk factors for cardiovascular disease? First, what is a risk factor? A risk factor is any attribute, any characteristic for a patient or any exposure of an individual that will increase the likelihood of developing a disease or health problem. In other words, a risk factor is something that makes disease more likely in an individual. So if there's something an individual will inherit or acquire or be exposed to that will make them, at risk of developing a disease condition, that is called a risk factor. So for cardiovascular disease, we know the risk factors, and they are carefully divided into two. The one we call non-modifiable risk factors. And these non-modifiable risk factors, God is the only one who can change them. The one all our medical education has taught us, and which we have deep understanding of, is the modifiable risk factors. So what are those unmodifiable risk factors that only God can change? It's your age. We age every blessed day. Every year we add 1 year to our age. The more you age, the more your risk of having a heart disease or a stroke. Sex. Males are at a higher risk than females as long as you want to still menstruating. Once you want to stop menstruating, the risk of cardiovascular disease increases, sometimes as strict that of the male. Race and ethnicity. You and I did not choose our sex, neither did we choose our ethnicity. Blacks are at a very high risk of cardiovascular disease. Any place you have blacks, the risk of having heart disease is quite high. Family history. If someone has a family history of hypertension or diabetes or early cardiovascular disease, that's also non-modifiable. So you can see these 4 factors can be changed. But believe you me, the happy thing that these 4 factors contribute only like 3% of the causes of heart disease and stroke. The remaining 97% are modifiable. They are treatable, they are manageable, they are preventable. Look at them. I've divided them into 2 big categories so that we can follow through. One category is behavior. The other one is biology, that's disease. These behavioral risk factors are risk factors we acquire by consciously or unconsciously doing the wrong things. We can start with unhealthy alcohol use. Alcohol may be beneficial if taken in moderation, but too much of alcohol use will damage the heart and may lead to stroke. Unhealthy diets. Everybody on this call knows what unhealthy diet, is all about. Too much fries, too much carbs, too much, good food, pastries, and all that, too much snacking, too much Coke, too much soft drink. These are all unhealthy diets. Less of fiber, less of vegetable and fruits, less of nuts. These are all unhealthy dietary practices. If you are doing all these things, you are, by your behavior, increasing your risk of cardiovascular disease. What about physical inactivity? Most of us do not do physical activity. At least 30 minutes of brisk walk in a day. 150 minutes of brisk walk in a week of 7 days. How about? Or you'll be amazed, and over 63% of Nigerians physically inactive. What about smoking? You smoke, you feel cool, or the person is buying with their money, cardiovascular disease that may happen. What about stress? You don't manage stress healthily. Maybe you have stress from job, from family, from pressure, and then you start smoking, you start taking alcohol. The person is buying cardiovascular disease with their money. Remember, these 5 I've mentioned here under behavior are completely lifestyle, choices. They are completely within your power to choose, these things. In other words, you may also decide not to drink alcohol in an unhealthy fashion. You may decide to eat right. You may decide to be physically active. You may decide to stop smoking. You may even decide not to ever smoke. You may decide to find healthier ways to manage your stress. You stay away from cardiovascular disease. On my right hand is the biological ones, the ones we are taught in school: hypertension, diabetes, obesity, dyslipidemia, that's a cholesterol problem, and high uric acid. The interesting thing is that these abnormal behaviors, these unhealthy behavioral patterns will definitely lead to hypertension. Anybody doing unhealthy alcohol, unhealthy diet, physically inactive, smoking, and stress may end up having hypertension or diabetes or obesity or dyslipidemia. If you are stressed, you have a lot of cortisol, that will increase your risk of obesity. Once you're obese, hypertension will set in, and diabetes and dyslipidemia. Once you're eating wrong foods, you're going to have obesity, you're going to have cholesterol, you're going to have high uric acid. Once you have obesity, risk of diabetes and hypertension increases. So you see how a unhealthy behavior, life will ultimately lead to the ones we use drugs for. There's no drug for these behavioral problems. These are decisions people consciously or unconsciously, you get into. Nobody ever buys, nobody ever uses drugs to treat this. So at least I have diet, they all lead to cardiovascular factors, high blood pressure, hypertension, obesity, diabetes, and elevated lipid profile. Now, these ones will lead to cardiovascular disease, heart attack, strokes, and heart failure. Remember, you see, these physical factors, these behavioral factors do not cause heart disease directly. They start by causing, the metabolic risk factors, which ultimately lead to, heart disease. But look at all these other ones here, globalization and all that. Leave all this. Let us focus on this. If you control your behavior, you definitely most likely avoid this mid-row. Once this mid-row is not there, the last row, which is heart disease and stroke, will not take place. So now I'm asked to discuss not to miss the signs and the red flags. I want to also divide it into two. The quiet signs that do not, mean anything, to the patient, but matters to you as a healthcare professional. So let's start discussing the quiet signs. Here, the patient doesn't have any symptom yet. Patient has no discomfort. Patient has no sign. But you as a healthcare professional can pick out what will lead to those signs. Let's start with elevated blood pressure, hypertension. Anybody who has a BP of more than 140/90 on several measurements may not have any chest pain or palpitations, but that high BP that's not going to be attended to will ultimately lead to these signs I'm going to point out later. Or somebody is diagnosed with hypertension, and all the time, they're not taking their drugs, or for one reason or the other, drugs are not working, and BP is still above 140/90. Ultimately, they will develop the signs and the red flags I'm going to discuss further down. Or somebody comes to a BP of more than 180/10, what we call severe hypertension. That is an important reason for the patient to be admitted. Such a patient can just, shout and develop and bleed into the brain. That will be a massive hemorrhagic stroke. They may not make it. People do annual checks. They do a fasting blood sugar, and it's between 100 to 125 milligrams per DL. They're not yet diabetic, but it's pre-diabetes. This kind of value, you have to work hard through diet to push back the numbers to less than 100. Or somebody comes one day, does random blood sugar, and it's above 200 and has symptoms. Or even they don't have symptoms, that is a diabetic range, value. Or someone does a fasting blood sugar, and it's above 125 milligrams. The person already has diabetes. Or someone does a BMI, and it's above 30. The person has obesity. These people do not have any single sign. They don't have any single symptom. They are very, very cool, calm, well-dressed. They laugh, they crack jokes with you. But these numbers are very dangerous numbers. These numbers are not healthy numbers. Or maybe you measure the person's waist circumference. For females, it's above 8 cm. For men, it's above 94 cm. These are all unhealthy values that can lead to heart disease. Or the patient who refuses to listen to medical advice. That patient is, a walking time bomb. Especially if the patient has all these things I've mentioned above. The person is a walking time bomb that can explode into either a stroke or heart attack. I'm speaking to healthcare professionals, so I'm allowed to use my language. Now, sometimes when we use this language, patients feel bad that we're panicking them. No. One of those we want to be politically correct, want to shape our minds so they don't feel bad. It's better they feel bad hearing the truth. And if they don't do anything about this, it's going to be real tough. In future. I'm tired of managing stroke, really. Managing heart failure. Because some of the patients spend money on your stage 4. Will they ever make it again? I'm not sure. So that's why, these numbers as healthcare professionals mean a lot to us. A patient having this kind of, harsh numbers, that's why I put them in red. See them down. You must see them down. Let them know and see the bigger picture. Someone was asking me, the young boy of 24 years, BP drugs if they're hypertensive. I say yes. I'll tell them I'm trying to say prevent you from having a stroke. It's simple as that. So these numbers are quiet numbers for the patient, but for us, they raise a red flag in our mind. They raise antenna. They make us more proactive. You know, this patient who doesn't have any symptoms or has this set of values that are harsh and reddish must be attended to. What about the noisy ones? Noisy ones, you know, happen when the patient, you know, has developed, you know, the symptom. As I use the word noisy, that one was quiet, but this one's noisy. The patient has cardiac pain of chest origin, which may indicate either an ongoing heart attack or heart attack that is in the process. This chest pain is just like pressure, like a pressure on the chest, sometimes center, sometimes under the left breast. Sometimes squeezy, it's like crushing kind of pain. It's not sharp. It's retrosternal, that is, you know, on the upper part of, you know, the abdomen and the chest where they meet. This chest pain of cardiac origin is usually precipitated by exertion. The patient or the individual walks a few steps, they clutch, they have to, you know, they develop the chest pain on walking a few distance or climbing stairs. When they rest, the pain goes away, but it progressively gets worse. The patient will tell him, doctor, when I walk from my bedroom to my toilet or to have my bath, I have this pain, I have this pressure. When I rest, I get better. Or when I walk from my house to my bus, I have to stop twice because of this pressure. Sometimes the pressure is like they can't breathe well. These are warning signs. These are early signs that something might be going wrong that could lead to a heart attack. Remember, heart attack is an emergency and it's a very, very big one on that. Sometimes, especially for women, for diabetics and the elderly, the chest pain may not be the classical thing I have described. It may be subtle. Maybe just like, you know, small indigestion, like they have a heartburn. Diabetics are very, very unlucky. At a certain age, you know, as a diabetic, the nerves get damaged by diabetes, so they don't sense pain. Even when they're having a heart attack, you know, they won't have any pain. But how will you know? They become unnecessarily, you know, sweaty, unnecessarily confused, have shortness of breath. So any diabetic who is sweating a lot or has this unexplained, you know, difficulty in breathing, please check. They could be having a heart attack. Simple ECG will show it. In the elderly too, elderly people, their nerves are also damaged from aging. They may not be able to have this pain I described above. But again, the happy thing is that not all chest pain is of cardiac, you know, origin. Most of the chest pains I see as a cardiologist don't have anything to do with heart disease. But the very few that are of cardiac origin, they're really, you know, a biggie. So again, you know, I just put up this picture to be able to show, you know, us, you know, so you see where the chest pain starts, you know, usually under the left, you know, under the, you know, breastbone. Sometimes, you know, it can be higher or lower, but the pain radiates, you know, to the left arm and to the forearm this way. You can feel this picture and all that. Sometimes the pain might sit here, so you think you have heartburn. And sometimes you take a lot of antacid or omeprazole, thinking it's heartburn, because the heart and the esophagus are, you know, immediate neighbors. Sometimes, you know, the pain goes into the jaw, into the neck, and inside the armpit. These are all, you know, things to suggest to you that this patient may have, you know, a heart attack. Sometimes this heart attack may present as difficulty in breathing, especially in the elderly and diabetics. They may present as palpitations. They may have nausea. They may sweat, cold sweat. They may become pale, unnecessarily anxious and weak. So these symptoms come to us as healthcare professionals every blessed day. They should not be trivialized. That's why, you know, if you see a cardiologist, you know, anything he wants to do an ECG. People ask me, why do you want to do an ECG? I said, I want to do an ECG because sometimes this heart, chest pain, you know, can masquerade as other things. Without a proper ECG, you will not be, you will. You miss, and if you miss out this one that's early, our ladies may not have this kind of thing I've described. Sometimes they may not have a squeezy chest pain. They may have undue shortness of breath. Theirs may only be nausea, or they may have anxiety and palpitations. Most times, because Please, our sisters in this house, I don't want to be, gender, I don't want to be a sexist. Or sometimes because we believe women have a lot of emotional issues when they come with this chest pain, this shortness of the elbows, or maybe you have an emotional problem. That is why heart attack kills a lot of women more than men, because most times we trivialize their symptoms. Having known this, no one comes to see me as a cardiologist with shortness of breath. I don't do ECG. No matter how small the palpitation is, even if the one is anxious, they must do an ECG. Because in the time past, we used to believe that because women are emotional, they have a lot of emotional issues, any small thing is their emotions. To lose so many women to heart disease, heart attack. So now we're talking about this, we see our women do not present where our women present. So you have to have this in your mind. Any lady who has palpitation, no matter how little, who thinks anxiety, maybe job anxiety, boyfriend, husband, all those things that worry them, please do an ECG, please. It's very, very important. That ECG might be the only time you have an idea that she has a heart disease. Not every anxiety is emotional for women. Some anxieties can be due to heart disease. Another noisy symptom, will be palpitations, awareness of the heartbeat, arrhythmias. The way God created us, we're not supposed to be aware of our heartbeat. By the time somebody is aware of the heartbeat, it indicates that an electrical abnormality with the conduction system of the heart. This palpitation, they come with dizzy spells, blackouts. They may sweat a lot. They may have chest pain. They may feel tired. They may have sudden loss of consciousness. They may even slump, and that will be it. Again, not all palpitations are of cardiac importance, but the doctor has to sit down with the patient and thoroughly and patiently listen to the doctor. If you're going to see me in my practice, whether in Little or where in my shop, people wait for hours to be attended to. I'm not in a hurry to see a patient. I'll take my time to listen, ask questions that may appear childish, may appear irrelevant, but the answers you're going to give me will help me in making up my mind whether indeed I need to worry about your heart. Again, I've put up this picture to show how palpitations, some fluttering in your chest, like butterfly flapping in your chest. They may feel unnecessarily dizzy. Some may even faint. Some may have shortness of breath. Some may have, chest pain. It's none of these symptoms. It's anything simple. As a healthcare professional, anybody who's having skipping on the heartbeat is an early warning sign. If you miss it, next time the patient will be in the mortuary, and we don't want that for anybody. What about shortness of breath? People have difficulty in breathing. It may indicate heart failure. Usually, this difficulty in breathing comes with activity. They walk some short steps, they climb steps, they begin to pant, unduly. The amount of exercise that makes them pant will be way, way, way too small to explain the shortness of breath or the panting. They may have difficulty lying flat, what you call autopnea. Sometimes at the middle of the night, they wake up, gasping for breath. It's as if the whole room is shut down. No single air is in the room. What to call PND, paroxysmal nocturnal dyspnea. This may be associated with cough. The cough usually once at night. Sometimes they may also have palpitations. Asthma shares these same symptoms with heart failure. So anybody who comes with shortness of breath, I'm not only thinking about asthma, I'm also, could this person be having heart failure? We have tests to do to know what to do. NT-proBNP rules it out. What about leg swelling? Legs should not be swollen. If there's leg swelling that's persistent, it might be heart disease, it might be kidney disease, it might be liver disease. Sometimes they may have facial puffiness, they have abdominal swelling. They get easily filled up with small amount of food. Sometimes they have change in their urinary pattern. The volume may either increase or reduce. The color may change. They may have pass urine more frequently or less frequently. Their urine may also be foamy. They may have shortness of breath. If the leg swelling is from liver disease, they may have jaundice. You see, somehow all these symptoms are related together. How do you know that they are related? You can only know when you sit down with the patient and asking those searching questions. So these are the symptoms of heart failure. They have shortness of breath, persistent cough or wheeze, easily tired. They have edema all over the place. Legs are swollen, tummy is swollen. They don't have appetite. Any small food they eat, their tummy gets filled up. When the shortness of breath gets too bad, oxygen delivery to the brain becomes reduced. They may become confused. They'll not be able to process information very well. They may be, so they may have impaired memory. They have increased heart rate. They may also feel dizzy. What about stroke, the biggie? Stroke, comes with simple, symptoms, what to call fast. The F means facial drooping. The person may not be able to smile, without looking funny. Their eyes or their mouth may deviate to one side. The A means arm weakness. The patient may not be able to raise both arms fully and keep it, raised. The S means slurred speech. Is speech slurred or coherent? Time, the T is time for urgent action. When these things are happening, you must call the emergency number immediately. In Nigeria, our emergency numbers are 112 and 767. 112 is federal government number, 767 is Lagos State number. If you can't reach anyone, call anybody, call your neighbor, call your maid, call your driver, call anybody you need to call. And look, I'm not feeling fine. Let them rush and come and attend to you. Take a look at this. So the F means facial deviation. You can see this beautiful lady, she has had a stroke. I can see the face is deviated. Look at her mouth too, shifted to one side. I'm sure this woman won't be able to talk clearly. Her speech will be coherent. Take a look at her hand. She has hand weakness. See, her cup fell off from her hand. Can see how badly her mouth is deviated. I'm sure this one will be dropping saliva, and her speech will be very slurred. Sometimes she may not be able to make coherent speech. And look at the time. This is a T. Call somebody. Call 112 767 or call anybody. You need to call immediately. Call anybody. Anybody. Of course, don't call the devil. Anybody. Anybody you need to call that you think can help you get medical attention and help urgently. So the other noisy signs of stroke that are not as classical as this, people may have persistent headaches, like a frontal headache or headache at the back. They will describe it as the worst headache they have ever had in their whole life. It's called thunderclap headache. It happens, the headache may happen for 1 or 2 days, the next time the person is unconscious, they will have bled into the brain. Sometimes these people may have this naggy headache. They may have busy spells. This patient may vomit or have nausea. This may be signs of impending stroke or sign that a stroke has taken place. They may have what's called ataxia. Ataxia is unsteadiness of gait. When they walk, they're unsteady. They shuffle, they dribble, and fall. They may have tremors. They may have seizures. They may have temporary loss of vision that recovers after a few minutes. Or they may have lost speech that recovers after a few minutes. They may have double vision. When they're looking at an object, the object is double. These are all subtle signs of either an impending stroke or a stroke has happened. So if you look at all these signs we're talking about as a doctor, that means you're going to spend at least 30 minutes with the patient to be able to be sure that you're not missing any sign. So how not to miss a sign? I've mentioned the signs. What do we do not to miss the signs? Because if you miss the signs, the patient will be in trouble. Spend time with the patient. Take proper history, take proper physical exams, spend time, ask the questions. This patient has paid to come and see you. This patient has left his home to come and see you because you are the only one who can interpret his symptoms and signs. Please spend time. If you see only one patient a day and see the patient correctly and the patient does not have any heart attack or stroke, you have done the best job. If you see 20 under 4 hours and 15 develop complications because of shabbiness in your approach, you haven't done any work. So spend time, ask questions, ask social questions, ask family history, ask even the ones that are irrelevant, please ask. The more you talk to the patient, the more the patient answers, and the more you will establish a rapport, a bond that will serve the patient better and help you look after the patient very well. If a patient comes into your consulting room and you see the patient under 10 minutes, the patient is not satisfied. Patients want to be heard. They have a story to tell. That's what we call it history. If you look at the word history very well, it's like his story. Just write history. I'll look at it very carefully. It's as if you have written his story. This patient has a story to tell, and the story must be told by the patient, and you must listen to the story. Effective communication. Patient has hypertension. Tell him or her they have high blood pressure that requires medication, and treatment is for life. I've had to see patients who told me they were told that BP is only for 4 weeks. They're getting a pack of amlodipine. After 4 weeks, they stop taking. Next time I'm seeing them with a stroke. What happened? I met with Dr. So and so 5 years ago. You gave me a one drug and say after that I should stop. If you have effectively communicated to the patient, one of those things to tell the patient is that hypertension, diabetes, these are lifelong conditions. They are chronic. They are treated for life. There's no time you will stop. If there's going to stop, if there's going to be a point where medicines will be stopped, both of you agree to get to that point. Make the patient see the bigger picture on why they should follow your advice. Tell them stories, share examples with them, especially the young people. Everybody wants to grow old into their 90s and see their children and great-grandchildren and all that. This patient, that is young, that's contesting why they should not take medicine. And then I let them know that they have so much years ahead of them. Let these years and years of potential and fruitfulness not be cut short by cardiovascular disease. I remember years ago, I saw a bank manager of one of these banks. He was 44, had a massive stroke. Massive stroke. One whole part of his body was fully and completely paralyzed. And as a young wife, with young children, do you think he'll be happy? He will not be happy. What if the issue was that, he refused to take his drug? On his sick bed, he'll be forever blaming himself. What if on that sick bed with that stroke, the doctor didn't tell him to continue with drugs? He will forever blame the doctor. So you see why you have to spend time with your patient and effectively communicate and document that you have told this patient what to do. Finally, we healthcare professionals should read more, attend more courses or more online courses, read around, topics that are of interest to us, medical topics, cardiovascular topics. You don't need to pay. Just Google. There are free websites for cardiovascular disease knowledge. Once, American College of Cardiology or European Heart Society release a guideline, it's free. So you read, attend seminars. Before you renew your license as a doctor and nurse, please attend that CPD. Attend those things, they help. Where you work, if your MD is not organizing seminars, tell the MD, please organize seminars. MD organize seminars. Invite, responsible to come and teach, come and refresh knowledge. I've done this cardiology for quarter of a century. I still attend update courses. I still read every blessed day so that I don't get rusty. If a doctor is rusty, the person who pays the price is the patient. A doctor who is rusty, the patient will pay the price, and it's a very big price to pay. So how not to miss, please spend time, effective communication, let the patient see the bigger picture of why they should remain healthy. And please, as healthcare professionals, please let us always upskill and update our knowledge. So importance of early detection and prevention of heart disease. I love this, Dr. David. He said we can prevent unnecessary death from heart disease. In our practice, our patients always must come. I tell my nurses, staff, any patient who cannot wait for me to finish with another patient can go and come back another day or go elsewhere. When you see a patient and die, you won't go to sleep. The memory will always be there. And if you are passionate about this thing, you don't want that to happen. So we must spend time because the patient comes first. So what to do with these signs? We have identified these signs. What do we do with them? First, it depends on the healthcare professional, really. If the healthcare professional can manage these signs, can treat these signs, please go ahead and treat according to the guidelines. If you think you are trained have skill, know well trained to handle this, please refer the patient. 7 every life doesn't mean you must treat everybody. 7 every life also means before I said, Jack, I have called neurologist, can you manage this case facility? If he says no, I'm referring, because I don't want to monkey around with somebody's health or life. Sometimes the patient require ICU care. I must make sure the patient gets referred to a proper ICU setting, because I don't want that patient to suffer a very, very bad outcome. So it depends on the healthcare professional. Your ability to practice medicine with fear of God and with good conscience will also swallow that oath. Whatever you can treat according to guidelines. Whatever you cannot treat, please refer. Remember, time is of the essence. The earlier you refer the patient, the more likely the patient is going to recover. Remember, we said late presentation also means that the patient may not recover early or may not even recover at all. So if we're able to identify these signs and we weigh ourselves, we don't have the capacity to treat, we refer. I am a cardiologist. There's some heart cases I see. I refer. Patient comes with a massive myocardial infarction that requires PCI, a stent. I don't have any cath lab in my facility. I refer to where they can get cath lab, cardiac catheterization done under 6 hours. So they can put a stent and open up that clogged artery so the heart muscle can, receive blood. Otherwise, they're going to die. So we must, identify what we can do with our skills and with the infrastructure we own as healthcare professionals or where we work. I work in Lut. There's some cases we see in Lut. Lut doesn't have a cath lab. We refer to where the patient can have cath lab. The management understands. We don't have a cath lab here, so I can't help this patient because I don't have a cath lab. So we move the patient to where they can have a cath lab, where there's a cath lab, and they get well. And then everybody's happy at the end of the day. Time is of the essence. If somebody has, myocardial infarction and comes to see me under 1 hour, I give the person a clot buster. And the patient, they open up the artery, the heart, the person recovers. If someone has a stroke and comes under 2 hours, we'll give an injection that will open up the artery, the person recovers. This is 21st century, practice. So that's why, we must identify what we can do within a, place of practice. What we can do when such a patient comes, that require more, we move, to where they can get that more they require to recover. Time is of the essence. So how do we prevent the signs and red flags? So I'm winding down. It comes down to prevention. There are 4 levels of prevention. I'll take one at a time. Because today is World Heart Day, so the emphasis is how do we prevent heart disease. So I'm taking my time to talk about prevention. Primordial prevention, that means this person does not have any heart disease at all. Does not have any heart disease, doesn't have any risk factor. The person is like the standard man who does not have hypertension, doesn't have diabetes, is not obese, and all that. What do we do? It's called primordial prevention. Healthy living, healthy dietary choices, physical activity of at least 150 minutes per week. If you can do more, fine. These days, people have smartwatches. You can buy a smartwatch and say, I'm going to do 10,000 steps a day. Indirectly, you are preventing yourself from becoming diabetic, obese, burning down unnecessary cholesterol. You can decide not to smoke. If you're a smoker, you can also decide to quit. If you are struggling with quitting smoking, you can come and see us. We have drugs that you take and you stop smoking. Although it's expensive, but it can be more expensive than having had a heart attack or a stroke. If you are stressed, everybody's stressed, find a way to manage stress. Join church, groups, social clubs, healthy relationships. People you can talk to, your pastor, your imam, somebody can exchange, somebody can, unburden your thoughts and what's bothering you. That's primary prevention. If you do this and do them religiously, you likely will stay away from, heart disease. Primary prevention comes when the person has developed risk factors. In primary prevention, there's no heart attack, there's no stroke, there's no heart failure. But the person has those risk factors that can lead to either heart failure or heart attack or stroke or sudden cardiac death. What are those risk factors? Hypertension, diabetes, obesity, cholesterol issue, uric acid. These people must receive medicine. Remember, in primordial prevention, there is no medicine. We're talking about healthy life choices, healthy life practices. What in primary prevention, the person has medical risk factor now. They're either hypertensive, either diabetic, they have obesity, or they have issues with cholesterol or uric acid. You give them medicine to control these risk factors. And we also have targets. Blood pressure must be controlled to the point it's less than 140/90 or even below with drugs. Hypertension and diabetes are chronic conditions for life. You will take medicines every blessed day. Why we're giving medicine is not because we hate you or we're punishing the patient. We're giving medicine because any BP that's above 140/90, the risk of cardiovascular disease increased by 50%. The risk of heart failure is over 50% for poorly controlled hypertension. The risk of stroke is 45% for those whose blood pressure are not well controlled. The risk of sudden death is 41% for those whose blood pressure are not controlled. The risk of chronic kidney disease that require dialysis is about 17% for those whose blood pressure is not well controlled. What for diabetes? The risk of heart attack and heart failure are twice higher in patients who have diabetes. Earlier on, I told you that women who are menstruating have low risk of heart disease, but when they're diabetic, that menstrual protection is lost on account of diabetes. So diabetes is a very, very dangerous thing. Blood sugar must be well controlled. Even if it requires even insulin, we must control that blood sugar. Otherwise, when they develop those complications, you still have to give them those drugs that we are running away from and treat those complications. They may have gangrene that may lead to amputation. They may have blindness from diabetes. They may have kidney damage. Remember, someone who has diabetes and develops chronic kidney disease that requires, kidney transplant. It's a very difficult thing to give them new kidneys because the diabetes will damage the kidney that you're going to transplant into them. So we must aggressively manage these risk factors. For those who are very, very obese, who have smart injections, who have semaglutide, who have we have Monjaro. Give them this, injections for 6 to 8 weeks. They will shrink down like leper. They will lose weight. They will be amazed. They will thank you for it because by losing weight, you are prevented from having heart disease. Secondary prevention. This person has had, heart failure, or has had heart attack, or has had a stroke. Whatever you are doing now is to prevent another one from happening. So you see how we move from no disease to risk factor to disease. So, and I don't want to get to this secondary prevention because it's just exercise in futility. You can't do much. But we can do a lot at the level of primary prevention as healthcare professionals. We can do so much at this primary because we know the drugs to use. We know the advice to give to the patient. We know how to, encourage the patient to be on this, to adhere to this advice so that they don't end up with any complication. Once complication has come, you will still do this primary prevention by treating the risk factors. You also manage all the problems. Tertiary prevention, reduce complication. Someone who has stroke, you have to get a physiotherapist, buy them, walking frame, get wheelchair, get commode, all sorts of, issues. More cost, more inconvenience for the patient, more inconvenience for the caregiver, more money spent on paying caregivers, all sorts of problems. You see how we have moved from no money, no drug, to all sorts of issues. So prevention is the only way to prevent these symptoms. So look at this slide again, health promotion and all that. I just completely discussed them in the previous slide. This is where we want to go. From primordial, we go to primary. We should never cross primary as healthcare professionals with any patient. If we can't, make them not to develop hypertension, we must make sure by encouragement and proper prescription that they do not develop complications. After that, you're doing secondary prevention, which is just nothing. So I'm winding down. Now let's look at the relationship again. So here is this guy here. Lord, bad, lifestyle choices. They will definitely end up somewhere here. Once this happens and you and I as healthcare professionals miss it out here, they will end up either having a stroke or heart disease. Remember, the lifestyle do not jump the mid-row to cause heart disease. They must first of all affect the mid-row, the mid-column. So we and I as healthcare professionals have been trained to manage this and also offer advice with respect to this. This one, yes, we have the skill, we have the drugs, but why allow somebody to have a stroke when it can be prevented? Why allow someone to have heart disease when you can easily pick up the signs and prevent it from progressing? So this is the, American Heart Association's essential eats. So eat better, be more physically active, quit smoking, get a healthy sleep up to 6 to 8 hours in a day, manage your weight, control your cholesterol, manage your blood sugar, and your blood pressure. So everybody, whether you're sick or you're not sick, should be able to imbibe, this, imbibe and practice this 8, essential, things about life. So primary prevention now, we treat the risk factors with guideline-directed medical therapy. We know drugs that must work. We know drugs that we know will control blood pressure and prevent heart disease. We must offer our patients these drugs. When we're treating hypertension, we must treat to target. What is that target? BP should be less than 140 over 90 for the regular people. For those who have high risk, we'll get it to 130, to less than 130 over 80. Blood sugar fasting should not be more than 100. And your LDL cholesterol, the one called bad cholesterol, should not be more than 100 as well. Secondary prevention. Yes, someone has had a heart attack or stroke. We must give aspirin, low dose aspirin like ampirine and 5 milligrams or clopidogrel for those who are aspirin sensitive. We must use statins like atorvastatin or rosuvastatin to prevent another stroke. We must still aggressively tackle the risk factors that have led up to the heart disease in the first place. And of course, careful, aggressive lifestyle adjustments. So winding down in summary, heart disease and stroke are the major causes of global death every year. Heart disease from stroke, death from heart disease and stroke usually comes with signs which must not be missed. Early detection of these signs and timely intervention, whether treatment or referral, is very, very important to prevent death. Prevention is cheaper, is safe, and better than cure. Thank you for your time. Thank you very much.
Thank you so much, Dr. Kasme Amadi. Yes, please, a round of applause for Dr. Kasme Amadi. I want to see all the reactions coming up. He has done justice to educating us as healthcare professionals in the best management practices for cardiovascular diseases, and also stated that the patient should always come first. I mean, I believe and I'm optimistic that we must have learned a lot from this webinar, thanks to Dr. Kasme. So yes, please, we'll go right into our question and answer session. Please make use of the chat box for your questions. Make use of the chat box for your questions. I believe a lot of us are itching to ask questions to clear our curiosity, because Dr. Kasme has done justice to this topic. I mean, thank you so much, Doctor. So for all our questions, please use the chat box. You can also use the question and answer section of the call to ask your questions. Mr. Umar and Abel, whose hands are raised, if you have questions, please use the chat box to ask your questions. Thank you. So we are going to dedicate a few minutes to question and answers. We are waiting for your questions. Okay, we are not receiving any questions from our end.
Now, when you present a topic or a seminar or whatever, and nobody asks a question, there are two angles to it.
Yes.
one, either everybody understood or there was no communication. So I don't know which one. Everybody
I want to
understood the
believe
topic.
everyone understood. But then please feel free to ask your questions. All HCPs on the call, please feel free to ask your questions. Dr. Amadi is very willing to take your questions. Okay, while we wait for our questions, just know that we would have our trivia coming up right after we send our questions for Dr. Kasme. And of course, it promises to be very interesting. So please, I'm really grateful for a lot of us that have stayed till the end. I mean, till now. Yeah, till now. That shows that.
There is a question in the question and answer platform.
Okay. So we'll be having our trivia session after the question and answer session. Thank you so much. Okay, so I was told we have a question. Let's go look at it. Okay, Dr. Kasme, we have a question for you. Someone says, are there instances where the underlying cause of high blood pressure is not known? If yes, can we go straight to using drugs that can lower the blood pressure? Okay, sir, that question was for you, sir.
No, you're breaking. You're breaking. Okay.
Okay. Can you hear me clearly now, sir?
Okay. Let me. I don't know. Like, is there any way I can share the
yes,
question?
I can share it on the chats box. Let me do that now. And we have a couple of questions coming up. Can you hear me clearly now, sir?
Okay. Okay. I can hear. Yes, I hear.
Okay, so our first question is, are there instances where the underlying cause of high blood pressure is not known? If yes, can we go straight to using drugs that can lower the blood pressure?
Okay. Yes, thank you for your question. It's a typical question. Now, talking about hypertension, hypertension can be divided into two, broad groups. The first one is called primary hypertension, which consists about 90% of all cases of hypertension. The cause is unknown, what is genetically, determined. While the remaining 10% or so is called secondary hypertension. In secondary hypertension, we have identifiable reasons why the person is hypertensive. So we deal with those reasons, usually due to endocrine problems. Someone may have adrenal tumor or whatever, and they have hypertension. So if you treat the underlying cause, where it can be identified, the person may not need any drug. What the common hypertension is primary, where the cause is unknown. What we believe is due to genetic, issues. So the person must, be on medicine, and medicine has to be given for life.
Okay, thank you so much.
So I don't know whether I was able to answer.
Well, I believe you were able to. I believe the HCP who asked that question is still on the call. So we have other questions here. How do we encourage patients to reduce their cholesterol?
Well, it boils down to lifestyle choices. We have identified, dietary practices that can increase cholesterol. Too much of fries, especially when you fry with, a cholesterol-laden oil, they're going to increase the cholesterol, in the food. When you take a lot of, pastries, things like cheese, they all increase cholesterol. and you take less of nuts, less of fiber, less of fruits and vegetables, you're pushing up cholesterol. So once you have identified that it's a dietary factor, you avoid those things and the cholesterol will come down. There's this myth about red meat and white meat. People live in red meat, in this case beef, and indulge in things like shaki, roundabout, the offals, cow leg, cow tail, long hump, those and all that, the intestines. Those things are heavily laden with cholesterol, more than the red meat. I've seen patients who believe that red meat has a lot of cholesterol, while these other ones they call white meat are free of cholesterol, and do a lot of the white meat and end up having high cholesterol. So once we're able to identify this dietary behaviors or dietary patterns that increase cholesterol, we speak against them and encourage patients to take a second look and make appropriate adjustments to their diet, and they'll be fine. Or sometimes the cholesterol level is so very high that you need medications, first of all, to get it down, in addition to the lifestyle dietary issues.
Okay, thank you so much, sir. Now we have a lot more questions coming up. Okay, what could be the causes of different reading in values of blood pressure after checking at different time? For example, 20 seconds different. This is another question.
Blood pressure changes from moment to moment, what we call blood pressure variability. So blood pressure readings vary from one point to another. So that's why we're not in a hurry to, treat blood pressure aggressively at the first meeting, because we know that a lot of factors, emotions, anxiety, environment, can affect blood pressure really. So we allow the individual or the patient to keep a record of their blood pressure over days and weeks. Then we can see, the trend. Once the trend is not above the set target, we won't worry. If I do your blood pressure, say by 3 p.m., I'm getting 120/70, and I measure it again around 4 p.m., I'm getting 120/70. Two things might be wrong. One, either I'm lying, or maybe the instrument is lying, because the way God has created blood pressure can't remain the same. It permits every minute it changes, but this fluctuation is within a range of normal values. So BP of 130/70 by 2 p.m. By 3 p.m. I may get 132, 134/74. It's still within the same range, but just it has changed because of what governs BP. Mechanism. The mechanism behind BP is quite dynamic, quite exuberant, changing from 1 second to another. But this fluctuation is usually within a range that we consider normal.
Okay, sir. We have another question here. How would you recognize heart failure presenting as asthmatic attack?
Well, it takes a high level of clinical insight to be able to do that. The patient definitely will come with but let me start this way. A known asthmatic is a known asthmatic. They'll be having a recurrent symptom of asthma and all that. They will wheeze, they will have chest tightness and all that. They also tell you they use their inhaler. That puts the person in one class, in one category. And if the person has hypertension, perhaps if the asthma is not responding to their usual use of inhalers, you might think that heart failure may be a contributory factor. A patient is a non-asthmatic, pops their inhaler from time to time when they have attacks and get well. But this time around, the attacks are not getting relieved by their usual use of inhalers. You might consider heart failure as a possible, differential diagnosis. For the patient you are bringing in for the first time, if the patient has asthma and heart failure, they share the same signs and symptoms. When you listen very intently to the lungs, you'll be able to pick, signs in the lungs that will carefully differentiate asthma from heart failure. Sometimes, again, it's not difficult to tell. Sometimes when you listen to the heart, you hear murmurs, you hear a third heart sound. Third heart sound is very specific for heart failure. So it begins to, shape your direction now. You begin to point a particular direction you should go. Again, that is not foolproof. So you have to go ahead and start medications, do echo, do NT-proBNP. Once NT-proBNP is normal, heart failure is ruled in, asthma is ruled out. NT-proBNP is only elevated in heart failure. So when we have these two conditions that have the same, set of symptoms and signs, and even when you examine, you're not so sure what is what, anti-problem people comes to the rescue, dividing the big line between heart failure and asthma, and leaving you with with the choices, you need to make. So first of all, high, clinical, you have to be clinically vast, high clinical insight to be able to, sometimes it's difficult, but you can start treatment. Remember, you want to save the life. Even if you start heart failure treatment and midway is asthma, fine. At least you have removed asthma from the way. If somebody has asthma, and interestingly, if somebody has asthma and it's heart failure, the ventolin puff opens up the airway, they breathe better. At least that buys you time before you do your anti-proBNP and the echo. So in places where we have very good setup, the patient comes in with shortness of breath, you pick the finger, put it on the machine, anti-proBNP is done under 5 minutes. Then, you wheel the patient in for echo under 30 minutes, you have your diagnosis on your table, So that's why we're asking for, better, more health funding, stronger health systems and infrastructure. And I think, we'll practice safer and better.
Okay, thank you so much, sir. We have another question here. Thanks for the lecture, sir. Low blood pressure, especially declining diastolic pressure below 70 millimeter mercury, is also being encountered as much as high blood pressure. What approach can we take in this instance?
Now, low blood pressure is something I find difficult to define and address, because what you're calling low blood pressure may be normal for the person. Somebody may have 96 as a normal blood pressure. You might be looking at this as a low blood pressure reading, but it's normal for the patient. Now, for you to define low blood pressure appropriately, you must start from a particular point and watch the trend of the blood pressure reading. Someone who has 90/70 as a normal blood pressure, the day you get 90/64, doesn't mean anything. The blood pressure that is low is a blood pressure that makes the patient feel dizzy. That is symptomatic. They feel dizzy. Lying down, no problem. Once they get up, they fall down, or they find it difficult to, maintain an erect position. So you have to look into that blood pressure. Low blood pressure is hardly ever due to over medication of a high blood pressure. With the new medicines in circulation, you hardly would treat blood pressure to very, very low levels. And if you're a very careful doctor, and your patient is adherent to your instructions of keeping the blood pressure reading, BP is 170, 100, I start medication. In 2 days, I'm getting 120, 70. Because no modern drug for hypertension crashes blood pressure like that. And you have to review that diagnosis, so you have to pull out your drug. However, if indeed it's confirmed to be low blood pressure, is secondary to something. There's an organic issue somewhere. There's a medical issue yet to be diagnosed that is causing that low blood pressure. If you think it's due to the medicines you are giving the patient, you take off the medicine for a while, and the blood pressure, picks up and gets to levels that are comfortable. So it's a difficult, concept to really, discuss. But again, it takes, very, great insight to be able to identify that indeed blood pressure is crashing. First, you must have a baseline. You must know what you did, at that baseline, and then follow through, with the readings, and be sure that it's not your medication. If your medication, fine and good, you take out the medication, 48 hours, blood pressure picks up again. If it's due to an underlying, problem, like endocrine problem, like Addison's disease, or maybe autonomic neuropathy and all that, these are all major issues that require proper attention and proper, intervention.
Okay, sir. Thank you so much. We have another question. Thank you, Dr. Kasmer, for an insightful session. Sir, if I heard you right, you said not all chest pain can be attributed to heart attack. How can I differentiate between chest pain associated with heart attack and one not associated with it?
Very good question. So now chest pain from heart attack has, some set of, characteristics. First is retrosternal at the upper border between the chest and the abdomen, or can be on top of the left side of the heart. That's if talking about location. Now, this pain is not there when the individual is at rest. The pain gets precipitated by physical activity or emotional activity. Maybe when they are stressed, when they are angry, they have this pain, or when they make some steps, when they walk some distance or climb stairs, they have this pain. It's not sharp. It's more like a heaviness, like you're boring into a hole. It's boring pain. A heaviness, like a pressure, like a squeeze kind of chest pain. Then it radiates into the axilla. Axilla is the armpit, can radiate into the neck, into the back, into the jaw. But when the person takes a rest, whether physical rest or mental rest, this pain goes away. The patient also should have some risk factors. Are they hypertensive? Are they elderly? Are they diabetic? Have they had long-standing history of smoking and all that? So that's one. So any pain that does not fit into this category is unlikely to be cardiac. However, it behoves the doctor to do an ECG. Heart attack is the diagnosis of heart attack follows 3 steps. Step number 1, the chest pain, followed by ECG and a blood assessment. The ECG will show you changes that are consistent with heart attack, and the blood level will show you elevated levels of elevated levels of troponin. Troponin is a biomarker, a marker in the blood that tells us that the individual has suffered a heart attack. So the symptoms, sometimes the symptoms may be vague, but ECG won't be vague. ECG and this elevated levels of troponin, firm up the diagnosis of cardiac chest pain. It's a tough call for cardiologists because you are struggling. Is it heart attack or otherwise? But these levels of diagnostic, guidelines, help us to, make that decision. So when you're not sure, please see your doctor. Your doctor will definitely order for an ECG and go ahead to do, troponin levels. Okay, any other question?
Rachel, you're muted.
I'm so sorry. Yes, we have a lot more questions here. The next question is, how can we treat hypertensive emergency?
Okay, fine. You define it by saying it's an emergency. An emergency. You tell the patient, is now hypertensive emergency. Let me define what it means so that we can also understand. This is severely elevated blood pressure above 180 or 110 with ongoing organ damage. So the BP is as high as 180 over 100 and above, over 110 and above, with ongoing organ damage. The organ damage may be heart failure, maybe heart attack, maybe an ischemic stroke, maybe a hemorrhagic stroke, maybe acute kidney shutdown, maybe pregnancy. These are the common ones, we see every day. The bigger ones are something we hardly see. I just mentioned the common ones so that we can relate. Someone who has a BP of above 180 over 110, with all these things constitute a hypertensive emergency. We're going to use IV medications. BP must be brought down under few seconds to few minutes. There's no time to monkey around because the organ is already compromised. Further wastage of time will further compromise organ vitality and organ function. So you use a lot of IVs. You can use IV labetalol, IV nitroprusside, also IV medications, load them, and get it done under a few seconds and a few minutes, then continue to oral and of course manage your organ failure. This is what it is in a nutshell, because this is on the medical class, but an emergency is an emergency. There are protocols to get blood pressure down, it's an emergency within a few seconds and a few minutes.
Okay, sir. What is the relationship between finger clubbing and underlying heart disease? And which specific cardiac conditions are most commonly associated with it?
Thank you for your question. Maybe you should enroll in a residency. We're looking for resident doctors, so this is purely a residency. Now, congenital heart disease, some of them can cause, finger clubbing. Cyanotic heart disease can cause, the pathology of fallow, transposition of great vessels and all that, are usually associated with finger clubbing. Some pulmonary conditions too, lung fibrosis, lung abscess, lung cancer, they all come with finger clubbing. Some GI causes as well. But for the cardiovascular causes, usually congenital heart disease, the cyanotic ones that make them bluish. The common ones, the radiology of Fallot, transfusion of great arteries, common right ventricle, common atria, they all come with finger, clubbing. And when we see that, we know that indeed there's a problem. And all we do is just to, manage the heart failure, go in and then repair the defect. Most in finger clubbing that go with heart failure, usually due to congenital heart disease. Sometimes infective endocarditis may lead to finger clubbing. Endocarditis, there's a valvular damage, there's infection of the heart valves, then you have finger clubbing. You treat and the patient, becomes well again. Whether the finger clubbing will reverse, I'm not so sure, because usually it's structural, damage that stays there.
Okay, sir. The next question is, leg swelling is often linked to heart failure, but what simple bedside features can help distinguish cardiac edema from renal or hepatic causes?
Okay, good. Cardiac edema. I examine the patient. There's a left jugular venous pressure. I'm assuming I'm talking to a doctor who sees this kind of thing every day. So leg edema is there. I examine the patient. There's a left jugular venous pressure. I look at the FSB. The FSB is displaced, maybe heaving or non-heaving. I auscultate. You have murmurs all over the place, showing that there's valvular issues. I listen to lung bases. They may have fine biversal crepitations. For liver, then in heart failure, there's usually hepatomegaly, there's liver enlargement. The liver span, is increased about 12 to 14 cm, or even be more. And maybe ascites and all, the usual thing. But for liver, disease causing bilateral leg swelling is a different kettle of fish. Now, the patient has this, bilaterally, leg edema. They may have ascites, which is water in the stomach, in the abdomen. They will hardly have JVP, elevated JVP. They will hardly have a third heart sound. When I look at their fingers, they may have finger clubbing. Their nails will be white, leukonickia. I look at their palm, they may have redness all over the place. They may have the pituitary contracture. All those signs of chronic liver disease can be seen on the fingers as well on the palm. They may have jaundice. Remember, when someone has leg edema and has jaundice, one of those things suspect will be liver thing. And then when you look at, you see, they may have breast enlargement from chronic liver disease. If they are males, they may have breast atrophy, shrinkage of the breast, substance. If they are females, if they are males, their testis is shrunken from the liver disease. If they are females, too, their liver may have, they don't usually have issues with their, genital system. For males, they will lose the typical, hair. They don't have hair. Female will develop hair like males. The usual things, we teach, people in medical school. So high clinical insight and all that will point, you in the right direction. But heart failure is a clinical diagnosis using Framingham criteria. Once you have leg swelling and have S3 and have JVP, you're good to go. But again, this is modern, medicine, modern cardiology. You do echo and all that. But if you vitally take the history, you'll be able to know what is what. Remember, in CLD, chronic liver disease, the liver is shrunken. They will hardly have a liver enlargement, unlike in heart failure, where you have liver enlargement. The liver is shrunken, and the liver is very, very rough, hard rock from fibrosis, from hardening, and all that. So, clinical acumen comes in a lot. Remember, as clinicians, our best, tool is our clinical, skills and acumen. The labs, support us here in this country. Abroad, I don't need to worry my head. I ask the patient to go and run a battery of tests and come back. The results help me. But here, you have to, dive below the symptoms and use your clinical acumen. And if when you are medical school, you read the Hutchinson very, very well, and you're a very good house officer and a good medical officer, those things have become second nature. It's just like a soldier who was taught how to shoot gun in the academy. Wake him up when he's 8, he knows how to clutch his rifle and knows how to shoot gun. So that's what I like about training. You are ingrained with the skills that If you become a president of the country for 5 years, 10 years, 100 years, you know how to use your stethoscope to pick up heart sounds. So good clinical insight, keep on practicing, keep on seeing more patients. If you're interested in studying internal medicine, come, we'll employ you immediately. We're looking for resident doctors to do internal medicine. Internal medicine is very cool, very cool, very cool. So next question, did I answer your question, please? Don't mind me, I drifted, but
I believe you have, sir. Okay, I have seen people with controlled BP suddenly have stroke. What could be the cause?
Very good question. Now, we don't have BP causes stroke, so hypertension causes stroke. And in addition, the other things in the blood, in fact, hypertension is the easiest risk factor for stroke everybody can identify. The measure BP is 120/70. What if the patient has atrial fibrillation? Unless you do an ECG. Or the patient is diabetic, you didn't know. What if the patient has high cholesterol? The person has very high uric acid. Or the patient has, connective tissue disease. So you see, when I said, spend time with the patient and don't be scared of running tests, where physicians will run tests. Surgeons are lucky here. You have a swelling, they take you into the tent and open up and then bring out the lump. But physicians will only depend on what the body fluids, yield. So you must run tests. Every hypertensive should go through some pattern of tests. And if your patient, adheres to medication and comes for review, you're able to pick out, signs that probably they have other things beyond hypertension that can cause, a stroke. What about diabetes? What about dyslipidemia? What about high uric acid? What about atrial fibrillation? What if they have a hole in the heart? If they have a hole in the heart, they can have what's called paradoxical, embolus that moves from the right to the left and causes a stroke. Or they have a clot in the left, apical chamber, left ventricular chamber. Maybe someday the thing just, leaves there and goes into the systemic circulation and causes a stroke. So, so we do the most like peeping through a keyhole, So, but the more the patient comes, the more you have rapport with the patient, the more you're able to identify subtle undocumented risk factors and handle them and deal with them.
Okay, sir. What are the chances of recovery for a stroke patient who has had a stroke for over 3 years?
The best time to recover from an acute stroke is within the first, 48, 72 hours, really, if you ask me. Because what happens in a stroke is that, the stroke has, ischemic stroke really has 2 layers of issues at that point in time. You have a particular layer which is completely dead because of cut in circulation. Circulation is cut off, that aspect of the brain dies. Adjacent to it, which is a wider zone, the zone that is dead from shortage of blood is a small zone. Adjacent to it is a wider zone. They are not dead yet, they are asleep, because of lack of blood flow. But if you perfuse the brain, give them enough fluid, unblock, you're going to salvage that big zone. The zone that is dead is called umbra. The zone that is not dead, that can salvage is called penumbra. So once you're an ischemic stroke, we want to, salvage the penumbra because that's a wider zone. So if we don't do anything within the first 24, 48 hours, that sleepy zone becomes permanently, damaged. So it widens the zone of the stroke. So we'll do our best to salvage that aspect and hope that the patient recovers. Thereafter, you do your risk factor and then do your physiotherapy. Physiotherapy is unending. Somebody may do physiotherapy for 3-4 years. Your physiotherapy knows what to do to make sure power is restored. Your physiotherapy knows what to do to make sure your function is also restored. But people do physio for 3-4 weeks, 3 months. I can understand it's quite painful and quite expensive, and they don't they give up. Again, proper communication. By the time you tell patient you have to do this physio for 1 year or 2 years before you get your life back, perhaps they may be able to go through it. But sometimes, either the doctor does not tell them in the whole journey, or maybe you tell them the whole journey, but they choose to do for 1 or 2 months and quit. So after 1 year, I don't know what else I will be doing. So that's the way. So as a doctor, the first 72 hours are the only 72 hours. Once that 72-hour window is gone, well, it's miracle. Medically speaking, you only have to do physio to recover whatever deficit they have and recover as much function as you can.
Okay, sir. We have another question here. What do you do for a patient with consistent blood pressure above 180/100 with normal body weight and tingling sensation in the left part of the body and has refused to go to a cardiologist? Sir, you said
please take it again. I didn't get the initial question, please.
Okay, I said, what do you do for a patient with consistent blood pressure above 180/100 with normal body weight and tingling sensation in the left part of the body and has refused to go see a cardiologist?
Okay, fine. So what you will do is to keep on encouraging the patient. If the patient is very close to you, can report the patient to their parents or to their wife or their husband. Report to where you can report. Because if nothing is done one day, I just leave it one day, I just leave it that way. It might get too bad that becomes very, 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 very bad. It gets too bad because to the point it gets really very, very bad. You know what I mean? So you keep on pushing, call whoever you need to call. What the patient refuses, you need the patient that you have done your best. Ignorance is no longer bliss, but the fact that you spoke up, you reported the patient to people who matter to them, maybe their family members or close friends and associates, and they refuse, you leave them alone now. Because the patient is an adult, so you can't force an adult to take medicine. So that, I think what you do is what you've been doing. Continue encouraging, encouraging, tell their loved ones, tell family members who are close to them. But again, there's an ethical issue. Why bother about it? Why disclose the patient's medical condition? Why divulge that? But again, we can understand that you're approaching from a point of love as a family member, as a close friend. You can yes, ethics won't there are really no ethical issues because you're talking from a point of view, and from public health point of view as well. You're doing the right thing by raising an alarm where there is one indeed. 180/100 with tingling is an alarming situation. Falling the tingling may not be anything. Falling the tingling might be a manifestation of a sensory stroke. The typical stroke we're all aware of is one that paralyzes the body. Sometimes stroke spares the muscle and damages the sensory system. So they may have one side will paralyze as a sense. They will have tingling, hotness, blah blah blah. But meantime, the muscles are also okay. Now that's what we call thalamic stroke. Stroke that affects the thalamus. That's what that takes care of sensation.
Okay.
So, any more for me?
Yes, we have quite a lot of questions for you.
Jesus Christ.
We still have more questions.
We have just 5 minutes. 5 minutes more for the question. 5 minutes.
All right. Okay. So this person asks, is it advisable for hypertensive patients to skip their drugs if their BP is well controlled? For example, can they go alternate days if blood pressure is well regulated?
So on the record, no, they're not meant to, stop the drugs. The 128 you are getting is just because, you're taking your drugs every day. These drugs have what we call legacy effect. Some of these beautiful drugs in the market, can control blood pressure so well that if you skip for days, you still have very good reading. Otherwise, off the record, they are not meant to stop medicines. Those, lovely, nice, readings you are getting are because the patient is on medications. And once you stop the medications, the blood pressure goes up. However, there's a kind of pattern you will get. That's why I said, please, they should document their blood pressure readings every day. Your doctor studies the pattern and may decide to say, okay, fine, let's do alternate day. It is not proper for you to decide to do alternate day without discussing with your doctor. Remember, nothing you're calling normal blood pressure might be something, else for the doctor. So the doctor places you on a set of medications and has asked you to monitor your BP readings, monitor and get back to him. If he sees a trend that will make for alternate day dosing of your medications, he will also tell you to do alternate day dosing of your medications. If that trend is not established by him, it's not fair on his own part for you to do that. Remember, when there's an issue, you see the one you're going to run to. And it's not fair on you because he's doing everything possible to protect your heart and your brain from suffering, damage. So if you're worried about your BP trend, please see your doctor. Sometimes we may have to reduce the dose of the drugs. If you're on, say, 10 milligrams of amlodipine, for instance, we might say do 5 or do 2.5. I rather reduce the dose and do it every day than do alternate day. Nobody knows when the blood pressure swings up. Nobody knows. Well, so we can control what we can control. Things we can't control, let us manage them very well. Take your drug every day. If you're not happy about the trend, please see your doctor. He will speak to the trend and adjust your medications as appropriate.
Okay, thank you very much, doctor. A final question here. A friend has been weak for quite some time, most times due to stress. Then recently she gets tired easily after little work. After checking the blood pressure yesterday, it was really low. She has been advised to take more glucose-containing food, and take enough rest. What do you think is to be done?
Okay, fine. Maybe what is causing the weakness may be stress. So I agree they should take, more. I subscribe to taking a lot of glucose drinks. What if you load the person with glucose and the pancreas fails? So the person should eat normally, normal food. You only give glucose drinks when there is documented, evidence of hypoglycemia. If it's weak, it doesn't mean that the person is having low sugar. The person can take any adequate rest and eat normally. If taking drinks anyway can, cause their energy to, energy burst, fine, they can go ahead, but with moderation. I rather eat regular food than, sip or take or gulp, fizzy drinks that sugar that's so high in sugar. Who knows? If the person's already secreting high cholesterol from the stress, you already have enough sugar, so you might tip the patient over to stress-induced diabetes. So it's a balance. If the person that has no low sugar, why ask the person to take, drinks? Eat well, rest well. The panacea for stress is rest and biofeedback mechanisms, where you talk to people talk to you, you take a vacation, rest, go to the gym, do spa, those things that make people happy, swim, hang out, healthy hangout anyway, pray, sing, dance. You do them for a couple of days, you get your energy back. And if you take time off work, or from your regular stressful environment, you go and recharge and come back, stronger and healthier, and continue. And of course, let me add again, 8 hours of sleep. 8 hours of sleep is very important. 8 hours of sleep every day, if you want to stay healthy, free of cardiovascular disease.
Okay, sir.
That would be all for now.
Okay, fine.
Yes. That will be all the questions for now. Thank you so much, Dr. Casimir, for your time. I've learned a lot personally, and I'm very optimistic that every other healthcare professional on the call has grasped a lot of knowledge from this webinar. Thank you so much, sir.